we're up here today, really, there's 3 of us here. There's actually 6 of us in total because we have 5 UC health systems around the state, geographically located. You probably know them all. And then my role, which I'm part of the Office of the President, but because of my background in healthcare, I'm able to do quite a bit with the health systems. And, we're at a very exciting time, and, we'll talk about, the UC, but I think as the speakers earlier today talked about, it's a tremendous transformational time in healthcare, and it's no different for the UCs. I mean, we are 5 academic medical centers, so in addition to our patient care environment, we have a tremendous amount of NIH and NSF funding that comes through, so our clinical research portfolio is arguably the best in the world. We have the teaching mission, so half of the doctors who practice in California today came out of one of the UCs, and that's everything from primary care to super specialists. So we have a tremendous mission of touching 14 million lives across the state in our combined electronic medical record software, but then also how it feeds back into clinical research and discovery, and then the teaching mission. And you can just see some of the statistics here in terms of our overall size, where we fit into in terms of size in the state, where we're ranked. We always kind of pat each other on the back when one of us ends up or one of us ends up on one of the national lists, because we take a lot of pride in what we do. Where academic medical centers really stem from a medical school and the hospital that was built right next door, we really have evolved into being 5 full-blown health systems providing care across the continuum. And that's brought to us opportunities and challenges. You can see, we just announced our annual results. We're almost a $10 billion operating revenue enterprise now. From a standpoint of the 5, the history has been really that they've been 5 autonomous academic medical centers / health systems. I got to the university about 2 years ago. When I got here, neither of these 2 guys were in their roles. Michael was playing a different role. Chuck was still in Vermont, and
And I was younger.
And you were younger, and so. One of the things that we embarked upon, because as our CEOs were recognizing the changes that were coming in healthcare and, the onslaught of value-based care, the changing reimbursement world, all the competition, the CIOs, we really came together and around something that was being kind of driven from the top called leverage scale for value, which was really to challenge every function, including IT, for how do we start working more like a unified enterprise. A UC health enterprise, because before then we didn't really have a UC health. It was really it was UCLA, it was UC Irvine, it was UCSD, it was UC Davis. And so, how do we start to think more like one organization, not losing our unique identities, because our identities, not only are tremendous at what they do in terms of taking care of patients, they also have tremendous brand recognition in their markets nationally and globally for what they do. So we don't want to lose that. It's kind of like the brands that you have under Procter & Gamble. You don't want to lose those things, but you want to build on top of them and trying to find the right balance of maintaining a level of individuality, but then thinking more like an enterprise is what I would call a journey that we're 2 years into and certainly not done with as we start to look at things. We are, very Epic-centric. 4 out of the 5 run Epic today. Chuck's going to talk about UC Irvine, which is currently running Allscripts as part of what he talks about. From an overall perspective, if you look at the IT spend, because that was one of the things that we really wasn't shared amongst the 5 before, we started really looking at what we were spending it on, the impact it was having, so we could start helping and learning from each other, just in terms of who was running something on Epic and who was going to revenue cycle next quarter. What did the first 3 that had gone, what did they learn? If Mike Menier, who's at Davis, were here today, he would tell you exactly in terms of how many months and how much pain was avoided by working with his peers. Again, something that didn't exist just a couple of years ago. And so, much like every health system, that we have within the state and within the country, we're undergoing a tremendous amount of transformation. our strength is in tertiary and quaternary care, but we certainly now, having grown into health systems, whether it's by opening clinics or buying clinics, partnering and affiliating, we have a tremendous footprint, but we're under the same challenges that everyone else is in terms of changing reimbursement. All of the regulatory requirements of reporting that we have, really reevaluating delivery models, whether they're technology enabled or just in terms of how care is changing and how we try to make sure the patient gets to the most cost effective point of care within the system. And then really trying to then layer that, what's the system. We tend to not use the word enterprise. It sounds a little too corporate for us in the education world, but the system, we call it system-wide layer that we want to put on top of that for how we work together. And part of what the CIOs have done is really put together a governance model. So, no one's in charge and we're all in charge and we're all accountable. And so we have a governance team of the 6 of us where we sit down and we really do jointly make decisions together. So it's not like a typical corporate structure that you might see with some of the other health systems around the state and the country. And so, we focus a lot on this concept. The term internally we call it is leverage scale for value, which is really, we've been 5 independent health systems. If we start talking as UC Health, how do we generate value? And again, as CIOs, it was a great opportunity for us to really define value in the eyes of our CEOs. Value is not just about IT figuring out how to cut costs, but IT now is underpinning so much of the clinical enterprise about what you do and how you treat patients and how you ensure that you're getting reimbursed. That, we define value as something that allowed us to, one, find ways to take commodity IT and lower the cost of doing them by working together and aggregating our size and scale. 2, where we were going making future investments, and like everyone else, we're looking at pop health, we're looking at deep analytics, machine learning, and how do we do those together so that the analogy I use is we used to spend $5 all to do the same thing 5 different times and have 5 different flavors of ice cream. If we could work together and spend $3 and return $2 back to patient care, we've done a really good thing, and that's value in the eyes of our patients and our board. The third thing is technology now is on the forefront, and we had some great speakers earlier today who talked about technology on the forefront of redefining how healthcare is practiced, and what healthcare will be like for when we reach our elderly years and when our children start having children. So we're defining also the transformational part. So we really have 3 levers that we're pulling on in terms of how we are generating value within the UC Health enterprise. And it's magic, but it's not magic, right? It's it comes from growth. We're helping the business grow. Technology is really driving that growth curve. We grew up 11% year over year this past year. That's pretty good in today's environment. But we're also leveraging our scale. So it's about growth and scale for us. And so it was interesting when, the CEOs, I think their first impression when we first came together was we were a little bit of a problem. Our costs, the IT budgets were growing out of control. The CFOs outed us. Did anyone ever have a CFO out the IT department? Your budget's growing faster than everyone else's, right? And I think part of that comes from if you haven't defined value in the right way, sometimes that can be the perception. And so we had the great opportunity of 5 CIOs sitting in front of 5 CEOs. These guys also usually have joint responsibilities reporting to their CEOs and to the deans of their medical schools. And then above all that, you have a chancellor, and you can imagine the chancellor of a place like UCLA is a pretty important and powerful person. They got a chance to get in front of that audience and really talk about the value that they were generating and that they could generate in terms of working together. And they kind of came and made a commitment. And again, it was turning that conversation from one of, you guys are costing too much, to look at all the things that we're doing and that we can be doing to help this organization grow. And they're going to get up and talk about some of these stories. And so, it's about lowering the curve on the things that are commodity and investing in an intelligent way into the things that are really growing value for the patient and for the bottom line. Our bottom line doesn't go back to shareholders. Our bottom line, believe it or not, what we do with that, it goes actually into our teaching mission. So a lot of what goes back into in terms of programs to make sure that we're educating doctors in the best possible way, that we're giving people from disadvantaged populations an opportunity to come and practice medicine or get care. All those programs get funded through what would be in a typical corporation a positive bottom line. So if you talk about the mission of UC, and if we ever let the changes in healthcare turn that bottom line from black to red, and this is a direct quote from our president, Janet Napolitano, it would sink the university, because that's a heck of a lot of money that goes back into the teaching and learning mission of the university. So it's very important that we, even though we don't have a profit motive, that we have a motive to make sure that there's black at the bottom line, so that we reinvest back into our teaching.
And Tom, just to add to that, the teaching mission obviously is critical on the medical school side. And the tuition, even though it's very expensive to go to medical school, it probably costs now $200,000 for a degree, that's just a small fraction of what it actually costs to train somebody. And so without the health systems being financially viable, you can't train the physicians that we need. And we already have a shortage of physicians in this country. So the UCs crank out some of the best physicians in the country. And if we can't support that with the basically funding that's coming in from the medical centers to put right back into the teaching and research mission, we certainly have a problem.
Yeah, absolutely. And so the CIOs, they seized the opportunity. They got in front of their executive leaders, and they basically said, we're part of the solution. We're part of the future. And then they painted a vision where they really talked about working, 5 individuals working in concert together in terms of making decisions jointly, improving the alignment between the organizations. Again, looking at doing the more, and again, a lot of you out there in the audience are doing the same things. We're doing it on an amazing scale. If you think about, kind of 5 health systems, 14 million patients, taking those common infrastructure services and really trying to figure out how do we squeeze dollars out of there and recover those dollars and reinvest them back into higher value-added investments, whether they be IT or non-IT related. Really helping the business really think about the changing delivery models, and we'll probably talk a little bit about clinical integrated networks in terms of expanding our footprint through new clinics and affiliations, which we're very aggressive in doing, and partnerships that a few years ago we never would have thought of or even considered, just that the competitive landscape has changed a lot. Thinking as a single enterprise. And then really making sure, because again, when you were individual health systems, you kind of had one master to deal with. But as we've gone into this kind of, 5 UC Health arrangements acting as peers, there's accountability across, sideways as well as up and down. And that's a new model, and we have to kind of align our objectives at our level, but also for our teams to make sure that they're thinking both at a local and at a system-wide level. So with that, I'm going to turn the next part over to Chuck to talk about leverage scale for value in a little bit more detail.
All right. Thanks, Tom. Thank you all for that rousing rendition. So what we did is about a little over a year ago, actually it was, I think my first meeting was my first or second week at UC Irvine in 2014. We got together, leveraging scale for value group, all the 5 CIOs, and we really started in that first column that you see there, the phase 1 formation and opportunity identification. So a lot of that was actually just getting to know each other, because some of us were new, some of us were there for a while but didn't have the relationships with the others, as Tom was talking about earlier, that the 5 medical centers acted very much as siloed organizations. So a lot of the work just in the first few months was, as we were, forming our plans, was also developing relationship. And luckily, I think, for all of us, and we've got some changes happening now, but, we all gelled together. And I think that was probably the most important part of getting this thing off the ground. And with the new people that we have, the new CIOs coming in that we have right now, we have a new one at UCSD, Chris Longhurst, and great addition to the team. And we'll be recruiting another at UC Davis that I'm sure will be an active participant as well. So we looked at what type of framework we need to create to make this thing work. How do we organize ourselves? We had to report out to, with Tom's help, to the Office of the President. So we had to figure out a way that we were going to do that. and then really get into the opportunity identification. That was probably the biggest thing, was to really sit there and say, okay, what can we do together that we haven't been doing that can not only flatten the cost curve, but then bend the cost curve in the future. And that became very challenging conversations, but it was important to get through that. And I'll show you some examples of what we came up with and where we are. Then as we moved into towards the end of FY15, which is still in calendar 2014, our fiscal year starts in July. And so last spring, we moved into phase 2, which is the implementing the initial opportunities, and one that was what we call the IT big buy, which I'll talk a little bit about. I've got a slide on that. That was kind of a no-brainer for us, collaborating on things that we all buy together, but we do separately. So bringing those together, doing one contracts, things like that, was a huge money saving for us. So some of that low-hanging fruit, we marched right into, and luckily there was some of that we could do. We also looked at shared leveraging best practices. So we started talking about the things that we were doing, whether it was in security or the EHR, or just what we thought we had as organizations that were best practices that could be shared across the other organizations. So we had a laundry list of those, which you'll see. And then we started into this defining what shared and federated services were. And so you can imagine we had a lot of activity going on in each one of the UCs. So we had to try to figure out, okay, which ones should we maybe stop and do those together in a shared way, and which ones could continue individually that then maybe the other 4 UCs could jump in on at the appropriate moment or towards the end of that particular, maybe it's an RFP process or something like that. So there was quite a bit of lining up all those initiatives that we had going and trying to decide which ones would be shared, which one would be federated. And then we also done a lot of piloting. We're still doing a lot of pilots, and I'll mention a couple of those right now, but we're not doing them just for the individual UCs now that we used to do in the past. Now when we pilot, all 4 are kind of watching that pilot and seeing what's going on there and seeing whether it's successful or not, whether we would want to jump in on that as a full-blown implementation of some sort. Yep. And I've got examples of those.
I was gonna just add something to that, because
you can try the other one if that.
Because Chuck raises a good point, right? I think when you're an organization of our size, there are places where it makes sense to aggregate and work together. But in areas, especially kind of the newer, the fringe areas, you almost want, I call it controlled experimentation. You do something on pop health, you do something on, big data analytics, and, I'll do something on, revenue cycle enhancement. So, and I think that's the other thing by working together is by knowing where we're all kind of experimenting with the next thing, it makes the next person who travels that path easier. And that easier might not necessarily always mean lower cost. It might actually mean faster time to implementation. When I look at, for example, when some of our sites were moving in Big Cajito, the first one who went up kind of gave some lessons learned to the second one. The second one got up faster, and they started getting value more quickly. I mean, that's another form of value. So I think we do it both on aggregating, but we also do it on kind of on the innovation side where we're more vigorously sharing.
I would just add to that, one of the advantages or necessities as a CIO in the health systems with academic medical centers is we have to allow our faculty to innovate. So, we do have that other piece of it where we can't always just be driving this from an IT standpoint. We have to allow the innovation by our extremely smart faculty and then help them grow that faster.
Good points. Basically on the phase 3 is where we are today and moving forward. We're beginning to implement a lot of initiatives that bend the curve, and I'll show you some of those. These guys talked about a couple of them. We're definitely starting into the strategic planning side of things, especially when you think about population health. Again, as an IT organization, I can't tell you how many organizations I've been in where IT leads strategy. It never should be that way, but it happens to be that way in a lot of organizations. I'm sure in a lot of yours it's that way. The business side a lot of times has to catch up. And we're a little bit in that mode right now, but the business side is starting to coalesce along with the IT strategy, so we're starting to pull that together as well. So that's pretty exciting stuff. And then also looking at just the people, process, technology alignments across the UCs at this point. You know, looking at our application portfolios and across the UCs and looking at areas where we're the same, and like Epic, except for UCI, at least in the next couple of months. And then other areas as well, other different types of applications as well. So this isn't a real slide from the standpoint of dollars and cents, but it does show you our first initiative was to really look at lowering the curve. You know, if we continued as 5 individual organizations doing what we're doing, all buying IBM, all buying Cisco at different times, we would end up in that top blue area. That's where our costs would be. The area that we're impacting right now by combining forces on something we call big IT big buy, where we're buying Cisco altogether, we're buying IBM altogether, storage systems, things like that, we're able to affect that red area. So now we're bringing that red area down to so now our curve is not so steep, I guess. You're never going to get to the point where you're bending it the other way, but what you're trying to do is reduce how steep that curve is over time. So that's what our first initiatives have been, to really affect that red area. And now, beginning now and into the rest of FY16, we're going to start going after the green area and really start putting some initiatives in place that, you know, slow the expense growth of the organization and really start to flatten that piece of this chart. So to give you an idea of the 2 things that we're trying to focus on. These are all the initiatives that we have out there. I'm going to walk through a few of them for you. And what we did was we come up with a chart here. These are value opportunities that we decided as a group that we should attack, but we had to kind of look at them in a way to see which ones we considered low-hanging fruit versus ones that were more complex. So we came up with this chart that just shows in the bottom quadrant, you could say, you know, lower. These are IT-driven. These are things that we could do on our own. And since, you know, they're less complex in that lower quadrant as well. So those are things we could start off with. And you can see that commodity IT buying that I mentioned is in there. That's a big one for us. We're just lining up things and buying it together at the same time. So those are easy ones. We don't have to have you know, executive leadership approval on these things. We don't have to bring in the organizational strategy. It's just something we can do as IT leaders in the UC. When you get up to the top left quadrant, you can see these are business driven. They may be not very complex, but they require the business side of the house to be on board and to be driving the strategy. So things like radiology decision support, and that's a really good example where the 5 chairs of radiology came together and actually worked together with us on an RFP and really drove that RFP to a solution where we actually picked a vendor and finished negotiations with that vendor. We're getting ready to implement that particular product for decision support. We could not have done that just as IT CIOs. We needed the radiology chairs to be involved in that. So that's why something like that would be there. Same with data warehouse. If you move to the right, on the bottom quadrant, you can see these things are, again, controlled by IT for the most part, but they're higher complexity. Consolidating the EHR hardware, you know, across the system, co-sourcing IT operations, all, you know, things that we're driving, but can be very, very complex because they do affect a large portion of the IT organizations. Then you get into the top quadrant on the right, and that's where you get into the really interesting stuff. But again, that requires, that's where you really need the organization's strategy to align with the IT strategy, because you're not going to pull off population health, a single enterprise imaging solution. Again, we would need the chairs to converge on that and agree on what PAC system we would use, or vendor-neutral archives, things like that. Then you get to the far right, you get into the community EHR hosting, or what Epic, in Epic's case, Epic Connects, which all the UCs are embarking on. And then you get to the really far one, which is the one that I'm in charge of, and which is kind of scary having it be on that bubble being where it is right now. But I just realized that. I'm starting to get nervous.
Yeah, we put that bubble right in the most complex, hardest position, but that's probably where it belongs.
Yeah. So I'm looking for other opportunities. So let me talk a little bit about that. So we're on Allscripts, and we have Siemens and Envision. We have some old systems, GE, IDX on the physician billing side, and a bunch of other stuff. And it really became clear to me when I got to UC Irvine that wasn't something that was going to be tenable in the long run, and especially when we started doing leveraging scale for value, and the other 4 UCs are on Epic. And, you know, we just felt like the redheaded stepchild all the time because we couldn't participate in a lot of these initiatives because we didn't have the right EHR. So really had nothing to do really with Allscripts and Siemens and GE, but it was time to modernize our application portfolio. So we had some choices we could make. We could go directly to Epic, just like everybody else does that's an academic medical center our size. But I thought we should get a little bit more creative in that since we have 4 other UC family members here and see what we could do. So we started some discussions with Epic first just to make sure they were on board that we could actually be a Connect customer of one of the other UCs. And Epic thought about it for a little while, and they were very energized and thought that this would be a really interesting project. So we like that. You got to have the vendor on your side before you start these things. And then we started to look out across the UCs to see, okay, let's see whether we can do this and which UC would be the best host for UC Irvine. As you know, if we're going to go into a Connect model, it means that we have to do certain things at UC Irvine. We're going to have to accept a lot of the build, of that particular organization, which means when you're dealing with physicians who are used to, they implemented Allscripts 19 different ways in 19 different clinics, that's going to be a hard sell. So we actually went into, we brought in some consulting help and actually went into doing a scorecard on ourselves to see whether we as UC Irvine were ready to be a customer of Connect, with some of the restraints that you have on the Connect model. And it was interesting. I mean, we scored well in some areas. In some areas, we know we have challenges, and I think on the clinician side, we definitely will have some challenges there. But we know what those are, so we're going in with our eyes wide open. And as I've threatened the medical executive teams, is that they really want Epic. They really, really want Epic. And basically, I've given them the guiding principles and the ground rules about accepting another UC's build. And if they don't, we stay on Allscripts. So that's pretty much the choice that they have right now. So I'm getting a lot of hems and haws around it, but they don't want to stay on Allscripts. So I think when it comes down to it, we'll put those guiding principles in place and be successful. So right now we're down to looking at just 2 of the UCs and doing a lot of due diligence on which one makes the most sense. Epic is helping us as well with that because they know their customer just as better than anybody. And but you can imagine a lot of the work that we have to go through around shared governance and SLAs and just looking under the covers of each of these organizations. And it's been great with the other CIOs. They've been super helpful opening up their organizations to our teams, our consultant teams that we have in. And going through their organizations and helping us scorecard them to see which one makes the most fit, the best fit for us. So we're actually getting close to hopefully making a decision here very soon. And hopefully in the first quarter of next year, we'll actually get this thing started, which is very exciting. The benefits are going to be huge. The timeline's so much shorter. The cost savings to the UC system and to UC Irvine will be tremendous. The collaboration, I think, of this, actually will be the first, I should say when we pull it off, not if, when we pull it off, we'll actually be the first academic medical center in the country to be a customer of a Connect. So that's pretty exciting. But I think that's bringing 2 academic medical centers together. When we look at the benefits of that, it's going to be huge for us. Having these clinicians collaborate together across 2 UCs, it's going to be so big for us. I mean, to me, it's 1 + 1 = 3. And then when we're looking at ongoing support costs in supporting Epic going forward, it's going to be, 1 + 1 = 0.5. It'll be something less on the cost side. So it just makes a whole lot of sense. And and when you talk about we talked about piloting earlier, this is actually kind of a big pilot, because one of the big things we've been talking about as a UC Medical Center group is, should we be on one instance of Epic and figure out a support model that then really truly bends that cost curve, right? So so this is going to be our big pilot to see, whether that pans out or not. And my hope, I'm sure it will. We have some smart people working on it. So I wanted to spend a little bit of time on that one, only because it's probably one of the biggest and hardest ones that we'll do in the UC system over the next 12 to 14 months, 18 months. Any comments from my gallery on that?
Good luck.
Got it.
We're right behind you, Chuck. Right there. Yes, we're right here. Literally right behind you.
Yeah. Thanks, Mike. And I fired Scott, so I guess I'm really on my own. Okay. All right, so some imperatives for FY16 that we've been working on, and we've really optimized the IT big buy. We're really chugging along on that. We're adding more and more vendors every day. We have the CTOs working on that, and I should mention that even though the 5 CIOs are together on a regular basis, we actually get together face-to-face once a month for an entire day, sometimes a day and a half, and then we have phone calls in between. So we're really serious about this. But we formed a CTO group. We formed a Chief Information Security Officer group as well, CISO group. We've got our business, our clinical analytics and business analytics leads together as well as another team. We have our CMIOs, CNIOs together working on EHR initiatives as well. And each one of the CIOs have kind of lead those groups. So UCSF is handling the business analytics. I'm doing the security group with the CISOs. Mike is handling the EHR initiative with the CMIOs. So we have the CIO, UC Davis, is doing the big buy. So we each have our teams under us, and we're working across organizations. It's kind of a really, even though we've gotten together as 5 CIOs, we've kind of forced our leads, our direct reports to get together as well. And they're starting to do things without us, which is what we want. A little scary sometimes, depending on where they go, but that's what you want. You want that to be organic and start to move just because they realize there's opportunities, not waiting for us to tell them what to do. So that's happening. The secure health information and infrastructure piece, we're actually in the process right now of doing this is a shared versus a federated one. We're doing an RFP for a security operations center right now across all 5 UCs, and that's being managed out of I think UC Davis? UCSF is leading that one. And whoever they pick for a security operations center, we've been involved, and all 5 UCs will go in under that. We're aligning security plans and standards. I'm in charge of that group, so we're doing a lot of work. You can imagine all our security plans across the 5 UCs were all over the place. We had different tools implemented. Some had data loss prevention, some did not. Just minimum security standards around encryption, things like that were all over the place. So the 5 CISOs are working together on that and really doing a great job on pulling that together, and we'll implement that across all 5. And then we'll start to standardize on our tool sets, going forward from there. And then this co-source shared data center. This is something that UCSF started a while back, and they brought us in on it. They had a big RFP out there, and we got to watch the scoring and keeping tabs on where they were going with it. And Joe Bankford, who's the CIO at UCSF, did a tremendous job on this whole process. And so we did award a contract. We actually, I think we have about 12 data centers between all 5 UCs, if you count backups and things like that we do. And we'll be going down to 2 data centers across all 5 Cs over the next 18 months to 2 years. So you can imagine, what the savings are, again, when you talk about bending the cost curve on something. So again, that was a federated model where one of the UCs ran with something, and then we all kind of came in on the back end of it because it was a great idea to do that. So we're moving forward with that. That actually helps when you think about our connect strategy around not only connect strategy in the communities, but going on one instance across the UCs. If we're all in the same data center, from a hardware perspective, that makes it a lot easier as well. Disaster recovery, business continuity is much easier to implement in that type of environment. So we've got a lot of initiatives that are complementary to each other as we go forward. So we line those up. So one of the things we always look at too is the cloud-based. As we do data centers, are they going to grow? Are they going to shrink? What is the cloud situation? So came up with this slide. This is our view of the cloud as the 5 CIOs right now. We're not quite ready for it at this point. I know there's security issues as well, but as a CIO, you never want to be sitting there and have a lost data center, somewhere. So now we're really working on that, bending the cost curve, as I mentioned earlier, and the data centers is one of the biggest things that we have going on right now. The value is, you can imagine, in the millions on this over the next 5 years. So huge. These are things that are just tremendous projects to work on, but just tremendous value to the UC. And we are a public institution, so this is public dollars that we're saving, for California. So it's a big part of our mission as well. Secure texting, that's another federated one. UC Davis went out and looked at secure texting and picked Tiger Text, and we all looked at it and said, that makes a lot of sense. So we did a UC contract on that, and we're all part of implementing secure texting across the system. We mentioned decision support, enterprise imaging solution. We mentioned the Security Operations Center. These are all big things that are happening in FY16. I didn't have Epic up there at UC Irvine because it just scares me too much every time I look at it. So I try to keep it off as many slides as possible. And what's the nice thing we have in California when you talk about the data center is something called Scenic, which is really a broadband connection that really allows us to put these data centers in anywhere we want and connect the data around the 5 UCs in a plug-and-play way that's very high speed. We don't have to worry about provisioning high broadband networks to get this all done. So this is something that was already in place, which was huge because it would make it a lot more difficult to work together without something like this in place. And so, so what we're trying to do is just, based on everything I talked about, is just re-envision, the IT function across the UCs. I'm not sure, where we'll be in 4 or 5 years, 6 years, but we are on a path to move towards a more centralized approach in some things, but also a federated or a local approach in other things. And that's some of the things that we're struggling with right now. We know things like core infrastructure standards, service delivery models. We should be doing that across all 5 UCs. Sharing the technology, system-wide partnerships, aligning our applications to our application portfolios. That all makes sense, but we also have local priorities as well. So we don't want to slow those things down. The last thing I want to have to do is go to leadership, whether it's medical leadership or my leadership, and say, I can't implement this thing right now because I've got to wait to get the other 4 UCs on board and do a corporate contract and all this kind of stuff. And we do have some of those type of initiatives. So we're always having those, and they're not battles, but conversations in our groups and that's where the transparency comes in. We've got to lay everything on the table that we're working on locally, and then try to see which ones make the most sense to do together and which ones, maybe it's because of speed, that we have to do individually, and then we'll figure it out later. So there are some of those as well, because you just can't stop everything that you're doing and move everything to a system level all at once. But we'll slowly evolve that, through a governance process that we're creating, and get to that point. So with that, I'm going to turn it over to Mike.
Thanks, Chuck. Happy birthday. It's incredible. He runs marathons too. Like, I drive marathons. That's pretty much what I do. So when I first became CIO, which is about 15 months now, so a month before Chuck started, I came into it as a medical informaticist. So I'm sitting in the first meeting with all the CIOs and Tom, and I'm hearing NAS, NOC, SOC, all of those terms, and I'm Googling what they stand for because I don't really know. But they've really welcomed me into the group, and I've learned a tremendous amount. And I think coming in from a medical background adds a little bit of a different spin to our conversations and the way I look at things, which is kind of nice. So I'm going to talk about how we can take IT to kind of that next level. Let's dream big, and I don't think it's possible for the UCs to do this unless we collaborate together. So I'm going to focus on really 3 pieces of that, really looking at the EHR. So what advantage can we get from leveraging our scale to the EHR? What is the business advantage by leveraging our scale? And then finally, the analytics advantage, which I think is really the most interesting. So as Chuck mentioned, we put together a work group of the CMIOs and CNIOs and said, you know, part of what we need to do is look at how the different UCs are using the EHR and where there have increases in efficiency or some novel ideas in the design of their EHRs. Bring that to the other groups. By sharing this across, we can leverage more value out of our EHRs, which are a significant investment. But if you look at Epic systems, for example, they're all pretty much built from the ground up. So, you know, you go to one place, there's one set of order sets. You go to another place, there's another set of order sets. So if there's hundreds of different types of order sets for chest pain, which one is correct? Are they all correct? Are they none of them correct? Who knows? But if we can look at that amongst 5 UCs, now we have the power of 5 organizations to really make that determination. And so what we were able to do is identify projects across each of the 5 UCs that aren't even EHR specific. So Allscripts, Epic, it doesn't matter. Really looking at how we can improve that. And so you can see on the slide here, there's projects that each one of the UCs is leading. And this group gets together in person every other month to basically sit down, get data from the different EHR groups, bring them together, and figure out how we're going to move forward with these. And we decided to focus on really one item per UC, because trying to do this is actually really, really hard. You know, if you want to take an implementation, for example, of the Choosing Wisely knowledge base, and there's hundreds of these things by different medical organizations, well, which ones do? You know, you don't start with 150 of them. You have to analyze your data and see where are the care gaps. And then you look at that across the UCs, and then you figure out how to do it. And turns out each one of the UCs probably have a couple of these alerts or clinical decision support in their system already. So we can see how they're working and then leverage them across the other UCs. So that's a really great example of bringing that group together and deriving value from our scale. So, you know, value is something that's so critical for a CIO to impart upon the rest of the organization. And I will argue that it's very hard to do in healthcare, because outcomes, patient outcomes is really what we're looking at, right? Did we reduce mortality? And you're not going to get that from an IT system, right? You're going to get that from processes that may involve an IT system, but you have to change everything about your care. So you're not going to be able to do this alone as a CIO or an IT organization. You need to get the business involved. You need to get leadership, clinicians, lean processes, everything you can. And then you can't take sole responsibility for that. So I can't say I put in Epic so our revenue is up because we're collecting more money than ever before. While I think that's true, I can't say that because there's so many other process changes that went in place on the financial side of things, on the physician side of things, that you can't just pin it down to an IT solution. So in order to really show value, I think, in terms to leadership of what IT can do, you need to partner with the business and have them tell leadership how much value you're getting out of IT. So again, we need to focus on business priorities and really look at where our critical investments and target them from the IT standpoint. And again, engaging leadership is really key. So, you know, being at the table when we're making strategic decisions, using the Connect model or being able to leverage our EHR as a strategy if we want to partner with community physicians. So that's a very, very powerful strategy. It is incredibly hard for a small practice to manage their own electronic health record. It's nearly impossible. And Epic won't even talk to you if you're a small practice. It's not feasible. So we can offer that to a practice across all the UCs and take that burden away from them. Now, meaningful use is being rolled into something called MIPS. I don't know, does anybody know what MIPS is? So MIPS is basically what CMS is moving towards in terms of value-based payments. And we'll talk a little bit about that. But 25% of it is going to be based on some form of meaningful use. We don't know. It's constantly changing what stage. I don't even know what stage we're in anymore, 2, 2.3, 2.5. But that's going to be critical. So if 25% of the CMS payments coming in are predicated on successfully meeting meaningful use, there's an incredible value of IT there. And smaller community organizations are not going to be able to succeed on meaningful use because of how onerous it is. So they're going to need help, and so we can leverage our scale to help them. So I think this is a really good opportunity there. And then, really looking at aligning with the evolving organization in terms of where we need to go. Now, everybody says we're going from volume-based care to value-based care. Has anybody heard that? Yeah. So I disagree somewhat with that statement. I don't think the volume part is going away. So I think we're going to have to provide the same amount of patient volume, but with higher value. And that's incredibly hard. We have not cracked that nut yet. And so we're going to, and I think, IT is going to be really critical to be able to figuring out how to do that. Anybody thinks that doctors are going to get to see less patients when we move to value is really, I think, deceiving themselves and hoping for something very good. But I don't think that's coming. So it's just important to think about. And then finally, I wanted to talk about analytics. And I think this is incredibly powerful. In order to do everything we talked about in this presentation, you need to have analytics. And so how can we do that in the UC by leveraging our scale is by bringing all our data together. So one of the initiatives we have for big data is to bring the 5 UC health systems data into a central data repository that we're using the Epic platform Cogito to put together. They actually changed the name. I think it's called Constellation now. But this shared data warehouse is going to have immense possibilities: research, population health, education. It's really incredible. And talking about population health, if you have all the data in one data warehouse, then you don't need to necessarily have 5 teams at each UC, one at each UC, managing heart failure. If we're going to take care of a population of heart failure patients, why don't we do that centrally? Why don't we have one team that's really, really skilled at it functioning for the UCs? So in order to do that, you need to have the technology platforms in place. You need to have big data in place in order to do that for a group. So I think this is one of the very exciting things you can do with a shared data platform in terms of population health. Community engagement. A clinically integrated network is dependent on improving quality across that network. That is the definition. If you cannot show improved quality, you do not qualify as a clinically integrated network. So in order to do that, you're going to need to aggregate data. And so bringing that data together into the shared UC data warehouse and being able to analyze that and look at that and provide metrics to our physicians and practices to see where we can improve our quality is going to be very, very key. And then, again, the value-based care advantage. So we're not going to solve the value-based care problem, especially without volume going down, unless we have analytics. And then I think, pie in the sky stuff is really precision medicine. And so in order to get there, you need to have a platform. And so this is kind of an illustration of what we're envisioning our big data analytics platform being. And you can see that overlying that is something very, very critical, and that's a governance. So in order to really be successful across 5 academic medical centers that are going to share data, you need to have a very strong governance. And so we're working on putting that into place. And then you can see the different platforms and the different use cases and then the different ways of visualizing the data that we will get to by combining our knowledge on the analytics and by bringing the data together. So I think it's really, really exciting on what we're going to be able to do. And, precision medicine, what is precision medicine? I mean, there's so many, everybody's saying precision medicine, like big data. What does it mean? Does it mean that you're going to walk into the physician's office and they're going to make you younger? I don't know. Maybe we'll have genetic therapies that will be able to do that. But what I think precision medicine means, and what we've talked about a lot, is that it's a platform of things. So you're going to require different things in order to enable precision medicine. And so you can see some of the pieces of that network, and we call it kind of a knowledge network of bringing different things together in order to enable a precision medicine platform. And so I'd like to walk you through kind of an example of what we envision precision medicine can be with big data and analytics. So let's say a patient comes into the clinic and sees their physician. And you collect some information about the patient. So you get their family history, you get some information about their vital signs, you listen to their heart, even though we learn that really doesn't work anymore. And then, you plug it into the EHR, and the EHR says, start a statin because it's going to reduce your risk of having a heart attack in the future. Great. But then we take it one step further, and we have some precision medicine tools that go in there. So now we can collect more information about the patient by looking at their genotype, taking the phenotypic information from the electronic health record and putting it together. And so we can then look at our big data, our analytics, and then say, okay, well, this person with just this genetic information and this phenotypic information matches patients in our data warehouse that look like this. And turns out that if you don't start a statin, they're actually going to have a better outcome. Because that's what we're seeing in patients that match specifically this patient. Not just their age or their past medical history, but their genomics. So it's pretty incredible. So then they come back to the doctor. So you come to UC Health. They come back to the doctor, and the doctor says, you know what, you really didn't need to be on that statin after all. You need to stop drinking soda, exercise a little bit, and you can control your risk even better than if you were taking a statin. That is the power of precision medicine, and we're going to get there. There's already companies looking at using genetic information to determine in real time your risk of having an interaction with a drug. We all know that medications have various effects on different people. Well, why? Well, there's probably a huge genetic component to that. And so some drugs in the same class of drugs may be better for one person with just this genomic distribution versus another. So we're going to be able to do that by bringing all the data together throughout the UCs. So I think it's very, very powerful. And so with that, you can see that all our mascots are collaborating on one page here. And this is kind of how our meeting goes. What was interesting to me is the UCSF mascot is an eagle. I did not know that. And then we have an anteater. Chuck, you guys are the anteaters.
Anteaters, yeah.
Yeah. So thank you guys very much, and we'd like to open it up to questions.